Welcome on Wisdom Teeth channel of Osteocom. Today's lesson is going to be on the surgical technique. First of all, we have to know that when we extract a wisdom tooth, we have to have a certain indication. And looking on the indications proposed by the American Association of Oral Maxillofacial Surgeons in 2016, we know that wisdom teeth are frequently associated with pathologies and diseases that are listed in literature. These can be like caries or cavities, pericoronitis, root resorption, periodontitis, infections, lesions of our surrounding bones like cysts, tumors, and mandibular fractures. We know that the absence of symptoms associated with third molars often does not correspond to the absence of pathology. So, in case of pathology, we will have to manage the treatment with the wisdom tooth extraction, whereas in the absence of symptoms, we will have to maintain a follow-up for a lifelong period. So, after some months or years, we will have to check up our patients to see that the situation has not changed. So now let's focus on the surgical technique. First of all, we have to decide what access flap we will choose to extract our tooth. We have different kinds of flaps, like the triangular flap, the marginal flap, the trapezoidal flap, and what we call the tailor-made flap. The triangular flap is the flap I personally prefer, and it's the one I use more often. This involves the intrasulcular incision on the seventh tooth with a distal buccal releasing incision that goes towards the ramus. We always have to remember that in this area, the mandible, the bone of the mandible of the ramus diverges towards the external part, and so our incision will have to be done directed towards the external buccal area. This obviously is a mini-invasive approach, and we can see an animation where we see the intrasulcular incision. It's a full thickness flap. We have to touch the bone, and then the releasing incision, the distal releasing incision, we see it here. It's going to be directed towards the vestibular part, and this will give us a complete elevation of our mucoperiosteal flap. Let's take a look at a clinical case with Francesco and his 4.8 impacted wisdom tooth. So, our triangular flap involves the intrasulcular incision of the 4.7 tooth and the distal releasing incision towards the buccal aspect of the jaw. We can see that this creates the elevation of a minimal invasive flap that exposes enough bone to reach our underlying tooth. After we perform the osteectomy, we can perform the tooth sectioning, the odontotomy, and then we can extract this wisdom tooth. And then we can see the primary closure of the flap with a 4.0 silk thread suture. Let's look at the marginal flap, which involves also the aspect of the first molar, and we can decide if the intrasulcular incision will involve the incision of the interdental papilla between the seventh tooth and the sixth tooth. And we can decide in this area if we want to do a papilla preservation flap, leaving the caul of the papilla on the underlying bone, or if we want to involve the papilla in the incision. And obviously, this is a longer incision that will give a better vision to the oral surgeon. So here we have a close-up of the papilla preservation where we see that the incision has left the papilla on the underlying bone. And in this area, depending on how we replace the flap once we finish our surgery, we can also decide not to suture in that area, not to place a suture in that area. So let's look at another clinical case. This is Alessandra, and we have a 3.8 tooth. A close-up, the clinical case, the clinical aspect before the surgery, a particular aspect in the middle where we see the papilla preservation flap, and then on the right image we can see the flap design completed. Then we have the elevation of the full thickness flap. It is always very important to see the underlying bone, the white underlying bone with no periosteum remnants, and this leads to a better healing of the wound. And then the other steps of bone sectioning and tooth sectioning, which will help us to remove the tooth, but we will look in detail on these aspects later. The trapezoidal flap will give us an even better vision of the bone because it involves two releasing incisions, a distal releasing incision distal to the wisdom tooth that we have to extract, and a mesial releasing incision that will give us a trapezoidal flap, and this obviously will give us a better intraoperative vision. Let's look at the case. We have Mattia with a 4.8 and also the 4.7 that has to be extracted, and also an associated bone lesion, which is a follicular cyst. And if we look at the steps, we see that this kind of flap gives us an important, good area of vision where there is no tension, and when we can perform our bone cutting and our tooth sectioning to remove the two teeth involved. And we will see here that there is also the tooth that has been extracted with the follicular associated lesion. And this makes us also see that in this particular case we had the inferior alveolar nerve outcoming in the underlying area of the tooth that we had extracted, and then after a clear and complete cleaning of the two sockets, we can perform a primary closure of our wound. So if we have to look at the advantages and drawbacks of these techniques, we have that the triangular flap gives us a smaller vision of the area, the marginal flap gives us a major vision of the area, whereas the trapezoidal flap gives us the major vision, and this maybe is indicated for surgeons and dentists which have a little bit less experience. Obviously, the wider we do the flap, and the major issues we can have at the end of the surgery regarding trismus and swelling of our patient. And also for the ease of suture, the fact that we don't perform two releasing incision in the triangular flap makes it easier to suture at the end of the surgery in comparison to the trapezoidal flap. Let's give a quick look at the tailor-made flap, where we can start to design smaller flaps. This is a small triangular flap that doesn't involve the 7th tooth. It is very minimally invasive. You have to have a good experience to use these kind of flaps. It's obviously up to the doctor's skills. It gives us less morbidity because obviously there is less exposure of the bone, but it is not so easy to handle. Let's look at this case, a 4.8, and we see that the design of the flap is actually a triangle, and it gives the only space, the working space, is obviously given by the base of this triangle. Here we start the luxation procedures, and then we perform the tooth sectioning, and then the closure of the wound once we extract the tooth. And in this case, I would say that making so many knots of the suture is not so easy to handle. So I prefer the triangular single flap I have just showed you. Now we can look into the ostectomy or bone cutting, bone sectioning around the tooth. This is used to expose the impacted tooth crown until the CEJ. I always suggest to start a small luxation of the tooth to give it a little movement inside at its socket, because it can be very useful if at the end of the extraction we have a fracture of the apexes. I suggest not to use these round burrs that are used on straight handpiece under constant irrigation of saline solution on the lingual aspect, because these burrs can create damage of the soft tissues. So if we want to do some bone section and bone cutting on the lingual aspect, I suggest using a piezoelectric piezosurgery device, which doesn't cut the soft tissues but has a selective cut on the hard tissues only. The tooth sectioning or odontosection is done to reduce the amount of bone that we have to remove around our tooth, and we will start to see which kind of lines we have to do to cut the tooth in order to extract it, depending on the position of the tooth. So depending on the fact that it has a normal version inclination or a mesial version inclination or a horizontal inclination or a distal inclination. We know that we have to do this kind of sectioning just cutting inside the tooth and not going outside of the tooth. We know that if we remain in the inner part of the tooth, we will not create any damage on the surrounding tooth. The sectioning of the tooth will be finalized with a lever, creating a direct fracture of the fragments we started to cut. So in a normal version, in a normal oriented, vertical oriented wisdom tooth, we will have to see if the tooth is a 1 or 2 root tooth. In case of a 2 root tooth, we will try to cut the tooth exactly in the middle in order to have 2 single roots fragments. Whereas in the normal version, so in the vertical aspect of these kind of teeth, we will have to remove the interference on the distal part of the tooth, which is normally covered by the vertical aspect of the jaw. In case of mesial inclined tooth, then we will have to cut the tooth if it is not completely covered by the 7th tooth, creating 2 monoradicular segments, so we can make a vertical cut to see and to cut the tooth in half. Whereas if the tooth is majorly angulated, we will have to consider it as a horizontal tooth, and this needs the fact that we have to make a primary cut at the level of the CEJ to remove the crown from the roots, and usually we will have to make another horizontal cut in the crown, because the mesial aspect of the wisdom tooth crown is going to be stuck under the equator of the 2nd molar. So this horizontal cut will make it possible to remove the distal aspect of the crown first and then approach the underlying mesial aspect of the crown. And then we will have to approach the roots. And we will have to see if these roots have a fusion at the end of the apexes or are two separated roots. The best thing is to cut the two roots in half so that we use the same approach as before, having two monoradicular roots. Or if this is a monoradicular root, we always, and I suggest to cut a little bit of the root in order to reduce the friction of the root that has to be pushed towards the mesial aspect for extraction. The distal inclined tooth is obviously the most difficult tooth to approach, and this needs a bigger bone sectioning on the distal vestibular aspect, because this tooth is going to be stuck towards the ascending ramus of the jaw. And also it is going to be not so easy to approach the positioning of our elevators, of our levers on the mesial aspect, because usually the two areas between the two roots are very, very close to each other. So for the luxation, I always suggest to remove any interference of the crown, of the upper parts of the tooth, so as to give more space to the roots to move, to use a small diameter elevator or lever to create a small space between the two adjacent roots. And once we have a small movement of the root, then we can use a larger lever to push the tooth towards the upper external area. Once we extract the tooth, then we will have to do the alveolar socket revision. And this is very important. This is very important because we have to remove all those areas of inflammation that have occurred, maybe due to the pericoronitis, which is the chronic inflammation that surrounds our wisdom tooth. And this is very important to avoid those late infections. 1 month after we finished our surgery, the patient calls us and it has a pus production from the distal part of the sulcus of the seventh tooth. And this may due to the fact that some remnants of the inflamed tissues have been left after the surgery. We always have to try to remove the follicular sac of the tooth, and we also have to rinse and wash thoroughly the cavity with saline solution. I suggest to use 2 20cc syringes of saline solution in order to remove any tooth particles, fragments, or any bone that has been detached during the luxation procedures. When we talk about the suture, our objectives is obviously to create the good hemostasis of the area, to prevent a pocket formation on the distal aspect of the second molar, and to restore the original anatomy. So I personally don't make any periosteal incision to always close for primary intention. I always tend to restore the flap where I found it. So if the tooth was completely impacted in the mucosa, then I will close the area for primary intention. Whereas if we have a partial eruption of the tooth, maybe of one cusp or even less, then I tend to leave a small area where we can have a small drainage of blood and inflammation. So I use 4.0 silk suture if the patient has a good hygiene of the mouth, if he follows our instruction, if I see that the surrounding tissues are not inflamed. In all the other instances, I use a synthetic monofilament suture. I use absorbable interwoven suture just when I know that I will not see the patient maybe for a while, or in the upper wisdom teeth extraction on the releasing incision, because I know that when I see my patient after a 1-week recall, I will have a little bit of edema and there will be no anesthesia, and so I don't want to force and pull the cheek to go and remove the stitches, and I can decide to leave them in place and let it absorb. I usually use 3/8 half round needles, taper cut figure of the needle. The suture, the first suture I apply is like a mattress suture, where you see I enter the buccal aspect of the flap, I get my suture on the lingual aspect, I then enter on the lingual aspect of the flap, which was not elevated. I exit on the buccal area of the flap, and then when we close the knot, you can see perfectly that the two areas close each other exactly behind the second molar, and this prevents from having some pseudo pockets or periodontal pockets on the distal aspects of the second molar. And this is a very important suture to close the gum just behind the second molar. And then I will close my releasing incision with single sutures, as I can show you in this animation. You see single sutures and then a mattress suture to close the distal aspect of the second molar, but we will see this in detail in the clinical cases. One last aspect, I usually perform an intramuscular injection of dexamethasone 4 milligrams as suggested in literature. I tended to do it on the end of my surgery, but now, as demonstrated in literature, I start doing this injection before the surgery, and this has demonstrated having less complications, less swelling, less trismus to the patient, less edema. So I suggest doing this kind of intramuscular application of dexamethasone in the buccal muscle, just on the buccinator close to the second molar. So I suggest you will follow us on the next lessons of osteocom. Thank you for staying with me.